Funding for Yale Cancer Answers is provided by Smilo Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about cancer prevention and improving outcomes with Dr. Michaela Dinan. Dr. Dinan is an associate professor of epidemiology at the Yale School of Public Health. Here's Dr. Weiner.
You know, you're in an area that may be a little less familiar to some of our listeners. You're not a medical doctor. You have a PhD. And how is it that you decided to go into this field? What triggered you when you were in college or after college to say this is the path I'm taking?
Yeah. So I initially became interested in the field of public health more broadly through exposure in my undergraduate studies, where I did my undergraduate studies at the University of Virginia. So it was in close proximity to Washington, D.C., and there were a lot of conferences there about science and the public interest, and they always needed volunteers at those conferences to help have those run. So I would volunteer and got that exposure, and I thought it was just an incredibly compelling area and decided to pursue my further educational studies in public health specifically. So I had already gotten into a PhD program in health policy, but my focus in cancer came about because of a deeply personal experience. And there's this quote by Andrew Lo that says that cancer is the great equalizer. Everyone is affected by it, either themselves or through loved ones. And I think that is so profoundly true, and certainly was true in my case. So I know you already are very familiar with this story, but both my father and his wife, my stepmother, were diagnosed with cancer within 2 weeks of each other, and they both started chemotherapy within 2 days of each other. And because of that, just horrible luck situation, they were both sick and undergoing treatment at the same time. And so my sisters and I and my fiance at the time were their primary caretakers. My fiance was in medical school, and he and I both took leave to care for my father in the hospital while he awaited his bone marrow transplant, while my sister stayed home with my stepmother while she was completing her incredibly arduous treatment. And the short version of the story is basically that she completed her treatment, survived, is now a long-term survivor of ovarian cancer, whereas my father, unfortunately, died within 4 months of his diagnosis. So we were married at his bedside in the hospital, and his funeral was actually the day I was supposed to start my PhD program. And both my new husband at the time and I went back home and immediately switched our educational focus to oncology. And we've dedicated our careers to that ever since, mine in cancer prevention control and him as a radiation oncologist and cancer researcher, as you well know. And this was 20 years ago this year, but, still is something that I carry with me every day in the work that I do.
I often say that for people who have had cancer, that both because of the arduous nature of the treatment at times and because of the way society perceives it, and because it's just scary for a lot of people, that there's a time in their life before cancer, and then there's the time after cancer. It's a big event.
Yeah.
And I'm struck listening to you how it wasn't you having cancer, it was your father and your stepmother having cancer, but it was a huge event for you.
Mm-hmm. Yeah.
And it changed your life.
Absolutely. There's this very short poem called Separation, and it goes, "Your absence has gone through me like thread through a needle. Everything I do is stitched with its color." And that's something that just is constantly in the back of my mind as I think about the work that we're doing here at Yale Cancer Center.
Well, and as you'll be able to describe, it's really great work. So maybe we could talk first about cancer prevention.
Yeah.
We often think about cancer treatment, but of course, the very best way to treat cancer is to not have it happen at all.
Yeah.
Where are we with cancer prevention and then we can talk about some of the challenges.
Sure. Yeah. So to be sure, especially given the story that I just told about my own family, there are many families with a family history of cancer, and that can absolutely translate to real elevated risk of cancer. And we're learning more and more about specific genes involved and how these risks are transmitted. There's also things like environmental exposures that can cause some specific cancers. And while I don't want to downplay the ability of known family history or specific carcinogens to impact a person's individual cancer risk, I think it's really important to note that although we don't know everything about cancer causes and risks, we actually know quite a bit. And as you just said, the preventable causes of cancer are the same kind of things that we've heard over and over again. And so, there was a study that came out just this summer in the Journal of Cancer that found that 40% of new cancer cases among adults ages 30 and older in the U.S. could be attributable to preventable risk factors. So we know, I think everybody's heard that smoking is the leading risk factor by far for cancer. But most people only think about smoking in the context of lung cancer, but it's actually a risk factor for several different types of cancer. I think the statistic was that smoking causes about 20% of all cancers and about 30% of all cancer deaths. Again, it's across multiple cancers, whereas when we think specifically about lung cancer, smoking causes about 80% of lung cancers as well as 80% of lung cancer death. Other things that people don't maybe think about as much in terms of preventable causes of cancer, alcohol use accounts for about 6% of all cancers and 4% of all cancer deaths in the U.S. And the World Health Organization has classified alcohol as a group 1 carcinogen since 1988, and yet many people don't think about the link between alcohol use and cancer. And then other key risk factors can include things like
alcohol and tobacco sometimes together can be synergistic in terms of a risk factor or risk factors, particularly for cancers of the head and neck and the esophagus.
Yeah, absolutely. And then, there's other key risk factors like body weight, excess body weight, physical inactivity, and low nutritional diet, and things like HPV. So these are all preventable. When we talk about cancer prevention, these are all things that we know and we can do something about in terms of preventing our chances of developing cancer.
So it's probably worth spending a minute focusing on body weight, because we now know that being overweight or obese is associated with many, many different types of cancer. But at the same time, as much as it's a problem that is increasing in the United States, it's also one that we have to be pretty sensitive to, because it's easy to get into a mindset of blaming the victim. And the last thing we want to do is make people feel badly about the way their body is. And instead, we want to help them try to get to a healthy weight.
Yes, absolutely. And I think that this is a case where, we often talk about in medicine, like dose response, right? And I think it's important to emphasize that this is a case where like every little bit helps, right? So it's not about trying to achieve perfection, but rather trying to make movements in the right direction, right? Like nobody, if we take all of these risk factors together, right? Like smoking, alcohol, physical inactivity, excess body weight, it's putting a lot, right? Like on an individual, like you have to be perfect in all of these. And I don't think that that's a realistic kind of thought, but knowing what the risk factors are and then trying to make sensible modifications in those spaces can really make a difference.
Yeah, no, I think that's a really important point. So how are we going to get people to increase physical activity or further decrease smoking? Smoking's gone way down over the past 30 years, but what's it going to take to eliminate tobacco use?
Well, so I wish I had the answer to that. So certainly there's an educational component to, right? So talking about these issues, it is interesting that when I do talk about cancer prevention and control, people often aren't familiar with the fact that tobacco use can cause other types of cancers other than just lung cancer. But certainly I know that Yale Cancer Center in particular has done a lot of work in trying to make smoking cessation programs more accessible to the community. And that's, in terms of when we talk about prevention, there's primary prevention, which is trying to prevent a disease from occurring. There's secondary prevention, which is screening to get earlier detection of disease. And then there's tertiary prevention, which is treatment to keep a disease from progressing, right? And so there's ongoing work at Yale and abroad to try to move the needle in each of those marks, right? So getting people to reduce or quit smoking so that they are less likely to have a cancer to begin with, increasing access to screening so that if they do experience a cancer, they're more likely to be diagnosed at an earlier stage. And then for those people who have to receive treatment, improving treatments so that they're less toxic and have better outcomes.
So on this show, we've talked a lot about cancer disparities and the fact that not everyone has equal access to cancer care, and that can result in excess suffering, excess death. But what do we know about disparities and prevention?
Sure. So as you said, we know that cancer disparities exist, and we know that they occur in multiple places along the cancer care continuum. So this includes accessing healthcare related to cancer prevention, such as, again, like smoking cessation programs or diet or exercise interventions, which are often available through healthcare systems as well. It can also relate to disparities in accessing and compliance with screening recommendations. So there's an educational component to that as well, because screening recommendations can and do change over time. So making sure people have the most up-to-date information about that. And then certainly, again, if you want to talk about tertiary prevention, which is preventing the progression or recurrence of disease, there's disparities that happen at the level of accessing and staying adherent to cancer treatment, which then impacts long-term outcomes for patients.
Sure. No, these are, these are all really important issues. And as we think more and more about cancer prevention and cancer screening, we have to make sure that we're providing the same kind of programs to people in all different aspects of our society.
Yeah. And you touched on a really important point earlier, I think, which is about, we don't want to put the burden of health disparities solely on the patient, but also looking at where providers of all types or institutional or geographic or policy drivers are drivers of disparities for patients as well, right? So there's work ongoing here to kind of look at all those different aspects of care and where we can make care more accessible.
And in terms of prevention and diet, we know that in less affluent areas, there simply aren't the same grocery stores.
Yes, that's absolutely true. So those types of factors will drive geographic or regional variation in the types of cancers that people experience, which are well known to be an issue as well.
All right. Well, we're going to just take a brief break. We will return in just a minute, and I'll be back with our guest this evening, Dr. Michaela Dinan, Associate Professor of Epidemiology at the Yale School of Public Health.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, offering spiritual care to patients and caregivers seeking peace in the midst of their cancer journey, while respecting the philosophies, spiritualities, and religions of patients and caregivers. SmilowCancerHospital.org. Genetic testing can be useful for people with certain types of cancer that seem to run in their families. Genetic counseling is a process that includes collecting a detailed personal and family history, a risk assessment, and a discussion of genetic testing options. Only about 5 to 10% of all cancers are inherited, and genetic testing is not recommended for everyone. Individuals who have a personal and/or family history that includes cancer at unusually early ages, multiple relatives on the same side of the family with the same cancer, more than one diagnosis of cancer in the same individual, rare cancers, or family history of a known altered cancer predisposing gene could be candidates for genetic testing. Resources for genetic counseling and testing are available at federally designated comprehensive cancer centers, such as Yale Cancer Center and its Milo Cancer Hospital. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
This is Eric Weiner again with Yale Cancer Answers, and I'm here with my guest, Dr. Michaela Dinan, Associate Professor of Epidemiology at the Yale School of Public Health and co-leader of the Cancer Prevention and Control Research Program in the Yale Cancer Center. If you could describe one or two projects, because I happen to know you have many ongoing projects, one or two that you're most excited about.
Yeah, thank you. So again, my work is maybe a little bit different from what you might hear on this program. And so my research specifically focuses on utilizing what we call real world data. And this can include things like claims data from insurance companies or data taken from electronic medical records from when people access the healthcare system for their cancer treatment. So we're looking at how people are interfacing with their cancer care in the real world, and then we're asking specific questions about that. So some of the projects that I'm most excited about right now we have a new study looking at comprehensive genomic profiling in cancer patients. So for those who aren't familiar, comprehensive genomic profiling allows for like the simultaneous testing for hundreds of genetic alterations in patients who have a diagnosis of cancer to help inform what their treatment options may be.
We're talking about testing the genes in the cancer itself.
Yes.
So this is somatic,
yes,
as opposed to germline, which are gene changes that could occur or that do occur in some people in every cell in their body.
Yes.
This is what makes a cancer a cancer.
Yes, very, very important distinction. So, these tests do exist and they are being utilized. And so our study is really trying to figure out, how are these tests being utilized in the real world, and then how that translates to changes in treatments for those patients, and then whether those changes in treatments then impact their actual outcomes.
And back to the disparities issue, does everybody have equal access to these tests?
Absolutely not. Anytime that there is a new emerging technology, whether that's in a diagnostic or a treatment for cancer, that always introduces or has at least the potential to introduce a disparity, right? So who is accessing this versus who is not able to access this. And we almost always see that access to new technologies, whether that's diagnostics or treatments, happen differentially in different subgroups of the population, almost always at higher rates in the more wealthy, educated, white populations.
I imagine the same is true in terms of new high-tech treatments.
Yes, diagnostics and treatments, that's correct.
Where, if anything, as we ask patients and family members to do more in terms of their care, and as the care and the various treatments become more expensive, disparities can increase unless we're very, very deliberate about how we approach these issues.
Yes, that's absolutely true. And that's why whenever we're looking at these questions, we're always looking at them in the contexts of costs, and particularly in the context of out-of-pocket costs for patients, because we know that those are one of many barriers that patients can experience in terms of accessing new diagnostics and new treatments.
So earlier we talked about when someone has cancer and life before cancer and life after cancer. For many people, like your stepmother, there's a long life after cancer.
That's right.
And that brings up issues related to survivorship.
Yes.
And what do we know about the kinds of stresses people face after a cancer diagnosis, many years after?
Yeah, so I also have an ongoing study in the space of long-term cancer survivors. And in this study, we are working to develop and then validate risk prediction algorithms to predict outcomes for long-term survivors that they often face after experiencing and being treated for a cancer diagnosis. So the things that we know that long-term survivors are at increased risk for include things like increased risk for cardiovascular events, increased risk for depression, increased risk for developing frailty. And then, of course, the things that are maybe of primary concern for a lot of long-term cancer survivors are looking at their risk for recurrence of disease, or even the development of a new primary malignancy, since unfortunately, oftentimes cancer survivors are at increased risk for developing a new primary malignancy as well.
And do you have a sense whether the frailty that sometimes develops after a person has had cancer is a result of having gone through the treatment, or to what extent is it related to the psychological stress of going through the diagnosis?
Yeah, I think it's both, right? And certainly as the landscape of treatment for cancer has changed, the toxicities and the long-term toxicities of those treatments have decreased. And you could probably talk a lot more eloquently about this than I can. But, so there have been improvements, and there will be continued improvements made in terms of trying to reduce the side effects and the long-term side effects that patients experience as part of their cancer treatment journey, but it does still happen. And then certainly, as you said, the stress and the psychological burden that comes with a cancer diagnosis and living with that, and that's something that you're going to carry around with you potentially, for the rest of your life. So there's going to be added, experiences from that as well.
Yeah, I've often wondered whether there are approaches that we can take when someone's going through cancer treatment that would speed up their recovery process.
Mm-hmm.
And I don't have any magic answer there.
Mm-hmm.
But if you imagine doing something, whether it's psychological support, whether it's physical therapy, whether it's changes in diet, if there are things that you could do that would allow someone to be the equivalent of a 5-year survivor at the 1-year point,
mm-hmm.
it would definitely improve their life.
Yeah, and I think all of those things that you just mentioned are great places to start. And there's evidence actually that already supports each of those in terms of, looking again at the same things that we talked about in terms of prevention. They come back around, right? So looking at improvements in diet, just increasing physical activity. I think psychological support is incredibly important as well, and is something that, we try to make available to patients here. But I also think there's a real need to change the narrative and culture around cancer survivorship. Like, I think we need to celebrate the transition from cancer care to survivorship care. It's a privilege to be able to transition from cancer care back to health care. And I think this should be framed as the goal we're aiming for with our cancer patients from day one of their care, so that if and when the transition takes place, it's a celebratory moment for both survivors and providers.
Sure. Maybe I can explore something that you talked about before,
Mm-hmm.
Not something I was necessarily planning to talk about with you today. But in talking about your father and
Mm-hmm.
your stepmother,
Yeah.
I think it raises issues about how important the family is,
Mm-hmm.
and family, and we'll say close friends, the support group.
Mm-hmm.
And what do we need to be doing as caregivers, as professional caregivers, for the caregivers in the family that are surrounding the patient? Do we do enough, and do we pay enough attention to them?
I think that this is a huge area of potential improvement, especially having played the role of a primary caregiver. And so, there's a lot of talk, and rightfully so, around patient navigation, right, for patients, but families need navigation as well. And I've often said, my husband and I have often reflected, we're both intimately involved with healthcare systems, right? And so if it's this hard for us, like, imagine what it must be like for somebody who doesn't have kind of the insider knowledge of a healthcare system, in terms of just being connected with all the various resources that are there to support you, because those resources may already be in place, but you're just not aware of them, right? So how do we create kind of a centralized resource to help, caregivers, family members, provide the very needed support for their family members undergoing cancer treatment, and then also being aware of the fact that caregiving itself takes a huge toll, a health, both mental and physical health toll on these people, and how do we support them in those ways as well?
Yeah, I think this is an area that we just don't talk about enough.
Mm-hmm.
We don't invest enough in the way of resources. And when I say we, I mean we as a society.
Agree. Mm-hmm.
Because, of course, any individual health system is to some extent at the mercy of what they can get covered in terms of insurance and other payment. But we really need to pay attention to these issues as a society. And I often wonder whether, in the end, we would, in fact, save resources and save dollars if we proactively provided the right kind of support.
I think that would absolutely be the case, given that, and there is a body of literature around this space that we know that caregivers, like primary caregivers of people who are suffering from, serious illness, that their physical health, again, also their emotional, mental, and spiritual health as well, but that at the very least, their physical health takes a direct impact, and that their health declines, right? So if you're just very unilaterally looking at it from would this save like healthcare dollars if we just took better care of these people from the beginning? I think the answer there is yes.
Yeah, and I think it's worth pointing out that this isn't just cancer related.
No, absolutely not.
People who are caregivers for individuals with dementia,
yep. Mm-hmm.
or severe cardiac disease,
mm-hmm.
or liver disease. We ask a lot of family members and friends these days as we discharge people earlier and earlier from the hospital, and we need to pay attention to them.
Yeah, absolutely. And then, this brings full circle back to our conversation about disparities. And, of course, there are resources that people can pay to help with, caregiving for a loved one. But again, there's that financial barrier again, right? So it's going to be limited to a select group of people who have that capability. So it's another way of then introducing these disparities potentially.
So in our last minute, I'm just going to ask you about another caregiving experience you've had, and that's the caregiving experience you have had and continue to have for your 11 cats.
Yes.
You should have known that I'd bring that up.
You know what? I should have, but I somehow didn't expect it. But you're right. I should have.
So for our listeners, Michaela has 11 cats that all have a inherited genetic mutation.
That's
and
right.
Maybe you could talk about them just for a minute.
Sure. So, my husband and I, maybe this is related to our caregiving experiences 20 years ago, who can say, but have devoted kind of our, outside of work time to rescuing and rehabilitating either traumatically injured or sick animals. And so I don't think started out thinking that we were going to get to 11, but we are now, in fact, at 11 as of recently. By your direct encouragement, I would add, Eric, we recently adopted a paraplegic cat and have been rapidly increasing our knowledge about how to properly care for a cat with those conditions. So, but I will say that I think we get far more out of it than we put in. Do we put in a lot of work? We do, but they're a fun group that bring us a lot of joy.
Dr. Michaela Dinan is an associate professor of epidemiology at the Yale School of Public Health. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.